All right. Can you guys hear me?
Yeah.
Sweet. Thanks for sticking it out today. I know we got some fresh powder last night, so if any of you, who's hitting the mountain after? Okay, I'll see you out there. Cool. So today I'm going to be talking a little bit about antibiotics in the ED, and we talk a lot about what we should be using, and we don't really talk about what we shouldn't be using. So today I'm going to give you kind of 3 pearls to take home on not necessarily specific antibiotics, but maybe classes or habits that we all have, and that myself I've recommended before. So the first thing we want to avoid, and we're going to start with a patient case, and this is a case that I had, a 66-year-old female with diabetes, hypertension, and Parkinson's, who shows up with acute onset of dysuria, urinary frequency, and a little CDA tenderness as well. All her labs come back, white count's normal, she's afebrile, vitals look great, and so I want to send her home, right? Most of us would. She's feeling a little crummy, so we decided to give her a gram of ceftriaxone, and then give her a course of Cipro for the next 7 days, and we discharge her. And there's this perception, right? So I kind of think of this like a paid programming ad, like a TV ad, right? So IV antibiotics, they're better. They're faster, and they're also stronger, right? I think that's a misconception that we have, especially in this scenario, and we'll talk a little bit about the literature surrounding this. There's not a ton, but then there's also some pharmacokinetics and logistics surrounding this that maybe we can try and avoid this practice. So the first thing I want to talk about is the oral bioavailability of the antibiotics that we commonly discharge patients on. And so we're giving this dose of ceftriaxone, right, because the bioavailability of an IV dose is 100%. We know that 100% of that dose we give will get into the patient's blood. But if you look at most of the antibiotics that we're going to be giving, pretty much all of them are greater than 50% bioavailable, and actually a large chunk of them are 80 to 100% bioavailable. So those oral doses we're giving are going to provide serum concentrations relative to the IV dose. They're going to be comparable. So the next thing we're going to talk about is the administration time. This is a big one for me because I see it causes a lot of delays, especially when we're talking about boarding patients, door to discharge times. When you order that IV antibiotic dose, it's easy for myself when I put in that dose not to really think about what's actually going to take the time and how long it's going to be. And so we're giving most of these medications over 30 to 60 minutes, right? Institutional guidelines. We have some data that show that we can maybe give them IV push, but for the most part, they're going to go over 30 to 60 minutes. Whereas if you order that oral dose of a comparable medication, it's going to be 3 to 5 minutes, right? We can get that in, get the patient going. It cuts down on nursing time, pharmacy time, and also that door to discharge time, which is so important. One I want to talk about a little more specifically that I see a lot for our cellulitis patients that come in where we want to give an MRSA agent is vancomycin. So it takes about 4 to 5 half-lives and 4 to 5 doses to reach a therapeutic level, right? This is basic pharmacokinetics we learned in pharmacy school, our P1 year. And when you just give that first dose in the emergency department, you're not actually really getting therapeutic levels for long. They've done some, there's been some literature in peri-op actually where they've given these single doses and looked at levels. And those levels by the end of the procedures over just a couple hours are already down to 2 or 5 mics per mil, and we're looking for greater than 10 for a therapeutic level. And then on top of that, you're talking about the administration time of 1 to 2 hours, depending on the dose. So again, you're just delaying that discharge when you're giving that vancomycin dose and then not providing them with just an oral up front. And the other thing with this too is when we provide that antibiotic up front, we're starting to get those serum levels up right away, whereas now we're giving a vancomycin dose, telling them to go home, take that antibiotic 12 hours later, and then that delays the time for that antibiotic to get to therapeutic levels. The last thing is going to be cost. So the cost is going to go up, and these are minor things, right? Usually we're looking for kind of big picture, where can we reduce costs? But you're increasing the cost of that patient stay every time you do an IV antibiotic or an IV in general. It also increases the nursing time and takes away from other things that they can be doing, as well as the pharmacy time as well. And so if we order the IV antibiotic as an oral, we'll start to cut down on those costs. We'll cut down on the nursing time needed, the pharmacy time needed as well. And so what clinical outcomes do we have that's associated with using oral versus IV before discharge? So we have really just 2 studies right now. We have no studies to support this practice. There's nothing that I can find in the literature, and one of these studies actually reported that they looked for it as well and could not find anything to support the practice. The first one we have is actually just published back in September in Pediatrics, and it looked at children with UTIs less than 2 years old and getting an IV antibiotic dose versus being just sent home on orals. And then they looked at the rates of revisits and treatment failure and found that there was no difference. And so we're basically giving those kids antibiotics for really no reason, and it's not really affecting any clinical outcomes. And then in an adult study about 4 years ago or 5 years ago, they looked at antibiotic-associated diarrhea, which is defined as greater than 3 loose stools per day for 2 days consecutively. And they took emergency department patients, about 250 of them, and then looked at risk factors for developing antibiotic-associated diarrhea, and found that the highest risk was actually when they were given that IV antibiotic dose prior to discharge. And so you're talking about rates of about 25% of patients having antibiotic-associated diarrhea versus only 12% of patients that got just oral antibiotics. So now we're affecting the clinical outcome. We're not affecting clinical outcomes in terms of revisits or treatment failure based on the pediatric literature, and then we're just causing more morbidity for these patients that might make them end up back in the ER if they're still having this diarrhea and can't be compliant with their antibiotic. And so our 66-year-old female patient, maybe we don't need all this equipment, we don't need an IV, she's looking a little crummy, make sure she can take PO, give her that oral antibiotic and send her home. And so my first pearl would be that it's the same, it's probably slower and maybe a little costlier. And so we should be avoiding these IV antibiotic doses prior to discharge. The next thing we want to avoid, we'll talk about in the same patient. So we got a bounce back, right? Who likes bounce backs?
Job security.
Okay, Peter says job security. I don't know about that, but so she's back, right? This is 4 days after that initial ER visit. Husband brings her in because she's been having this diarrhea for 4 days since she got the initial antibiotics. She then became confused. She was having memory issues, and the husband was concerned, so we brought her back. She comes in today. Her renal function is now impaired. Her creatinine's doubled. Her white count's fine. Her vitals are fine. She's a little maybe soft on the blood pressures, but overall just looks more fluid down from this diarrhea. And then you're kind of wondering, okay, it's probably either a worsening UTI, maybe in combination with this dehydration, that is causing all these confusion and memory impairment and things. But as a pharmacist, when I'm in the emergency department, I'm looking at the fluoroquinolone. And so how many of you have prescribed fluoroquinolone in the last month? Okay, so quite a few of you. So we have 6 available, and there's 3 that you likely are more familiar with, and then we use them for all sorts of different infections, right? They're approved kind of across the board depending on what fluoroquinolone you're looking at. But after these came out, there started to be a trend in the FDA starting to warn us about some things. And so we're probably all familiar with the tendon rupture, right? I think it was pretty scary when it first came out. People kind of got a little leery on prescribing these, but then time went on, and you know that risk, you realize it's pretty low, and so you start prescribing them more. Well, then you keep going. Now in 2011 and 2013, we've got worsening myasthenia gravis in myasthenia gravis patients, and also peripheral neuropathies. And these were peripheral neuropathies that are debilitating and can happen years out in some reports. We keep moving through the decades, and now you have uncomplicated infection restrictions. So the FDA is basically saying these are disabling side effects, and you need to restrict your antibiotics for uncomplicated infections, specifically fluoroquinolones. How many of you have prescribed fluoroquinolone for a UTI in the past month? And that's probably one of the most common, right? And then in 2018, there was more. It's like a party. They're just like hating on fluoroquinolones. Hey, look at this data. Hey, look at this data. And you see that just in December, actually right after I initially gave this talk the first time, this same day, which I thought was a little ironic, they came out with aortic dissection and aneurysms as a possible risk, which is a big one, right? That one's scary. Also hypoglycemia as another one. And then mental health side effects as well. And so the mental health side effects was basically just reconfirming what we already knew, that they cause these neuropsychiatric events, but they were defining them a little bit more with memory impairment, confusion, agitation, and delirium. Only one of these we can treat, right? We can treat hypoglycemia based on how Kyle would treat it. And the rest of them, the only thing we can do is prevent it by avoiding these antibiotics. And so how does this actually happen? Well, we won't go through all of them, but a couple of them. So the hypoglycemia, when you have fluoroquinolones floating around and it floats around the pancreas, it binds some calcium channel receptors on the beta cells and actually enhances glucose-induced insulin secretion. It also can cause insulin secretion on its own. And then in patients who are diabetic on sulfonylureas, it actually decreases their excretion as well. So you're putting these patients at risk in kind of multiple different ways without even them necessarily needing to be diabetic. And so when the FDA came out with this, they had 67 cases that they were reporting, and 70% were diabetic and 74% were on sulfonylureas. And so there's obviously some signal that these patients are more prone if they're diabetic on sulfonylureas based on the mechanism that we know. But then you also have to think that 30% weren't diabetic, which is pretty incredible when you think about it. Out of these 67 cases, 13 of them died, and then of the ones that still lived, 9 had neurologic impairment that was permanent. So these are serious adverse events. What about the neuropsychiatric effects? So it's proposed that it's actually NMDA agonism and GABA antagonism is how the fluoroquinolones actually cause this. And when we start to look at the literature and the major clinical trials, just in the general population, we're talking less than 1% incidence. And so this is why when they first got approved, no one was really concerned about it. But then when we start looking more so at high-risk populations, so I'm starting to talk a lot about the elderly, and then you'll see as you look through the literature, patients with acute kidney injury or renal dysfunction in general are at higher risk. And so there was a study this past year that looked at the VA population, about 630 patients. And they looked at inpatients that were on a fluoroquinolone and then how often they were associated with some sort of neuropsychiatric event, the most common being delirium. And they found almost a 4% incidence of this, so 1 in 25 patients had some neuropsychiatric events. And then when they looked at it by every decade of life, so as they got older, there was a 1.8 times increase in the incidence of this. And so they also found patients with Parkinson's, renal dysfunction, as well as some certain medication classes, like if they were on a typical antipsychotic already, they were at a higher risk. And so our patient's at a higher risk for this, right? With the renal dysfunction, with her elderly age, she's got Parkinson's. So these are things that I'm looking for when that patient presents to the ED. And then we didn't get to everything else, right? C. diff is another risk with them. It's fairly high, maybe not as high as some of the other antibiotic classes. QTC prolongation as well as the aortic aneurysm and dissection, right? We didn't even get to any of that. So these things just pile up, and so we should really be avoiding fluoroquinolones, especially when we have other options, when the patient doesn't have allergies, when there's no resistance based on their prior history, and especially for these uncomplicated infections. If I could make a pie chart like Kyle that just says never on it, I would do that for this, but I can't probably ethically do it with an antibiotic. The last thing I want to talk about is the same patient. It's another bounce back. This one's 2 months later though, so it doesn't look as bad, right? This time she's coming in, her legs are swollen, they're red, they're painful, she's slightly confused. She's had this recurrent UTI over the last 2 months that the physician has been having difficulty treating as an outpatient. She's also had diarrhea. What do you think we're going to throw at her when she comes in and she's febrile and tachycardic? It's okay, you can talk. Broad spectrum antibiotics. Ceftriaxone. Zosyn. Okay. Cefepime. All right. So we're talking broad spectrum. I know one that gets commonly used because it's easy and it basically covers everything. Zosyn Vanco, right? She doesn't have any MRSA risk factors, but I see it commonly prescribed in these patients where you don't really know what's happening. You know they're probably septic. So let's throw some, as it's affectionately called, Vosin at them. I prefer Zanco. I think that one sounds cooler. So that gets thrown at this patient. What do you think is going to happen though? Well, there's now some literature to support that this is going to cause some kidney injury. So we know Vanco is well correlated with kidney injury, and that's caused by oxidative stress and eventually renal tubular ischemia. It's associated with doses of greater than 4 grams, greater than or equal to 6 days of duration, as well as elevated trough levels, right? These are things that I focus on as a pharmacist on the inpatient side, because it's cool. But really, we don't really know what Zosyn does. We know there's maybe some correlation to acute kidney injury monotherapy, but in combination, it may actually be worse. And so why do we care? AKI is associated with mortality that's increased by 6.5 times in hospitalized patients, and then also the hospital length of stay is increased by 3.5 times. This might be a marker of their disease severity, right? But at the same time, we want to make sure we're basically decreasing the AKI rates as much as possible. And so there was about like 50 studies. They were all very low level that came out in the last 5 to 8 years that were looking at this exact question of whether the combination of Zosyn and Vanco induce an AKI as compared to other antibiotics that we prescribe. And so last year in Crit Care Medicine in January, actually about a year ago, there was a meta-analysis published where they looked at these comparisons. So Pictazo-Vanco compared to all 3 of these. So Vanco alone, a carbapenem or cefepime plus Vanco, and then Pictazo alone. And what they found was that Pictazo actually had 3.4 times the risk versus vancomycin alone for AKI. They also found that Pictazo and Vanco versus carbapenem and cefepime plus Vanco was 2.7 times increased risk of AKI. And then it was the exact same with Pictazo alone as well. These were all statistically significant. Again, you have to look at the data. It's not the best data going into the meta-analysis, but it was a fairly well done study. And so we think one and done, right? We stretch our arms, we're like, covered them, now they're going inpatient, they can decide. But the time matters. So anecdotally, what I see as a pharmacist is that the antibiotics that we choose in the ER get continued on the inpatient stay. So if we're choosing Zosyn Vanco, a lot of times those patients are going to continue on Zosyn Vanco, and the time to AKI in the studies was anywhere from 2 to 5 days. So by the time they're getting cultures back, they're going to start de-escalating antibiotics. You could have already induced that AKI based on the antibiotics that you chose in the emergency department. There's some issues with these studies, but due to lack of time, I won't go through them. And then the number needed to harm based on this meta-analysis was 11 patients. So every 11 patients that you prescribe Zosyn Vanco, which I see quite a few a week get Zosyn Vanco, that causes an AKI. And so in this patient, we should really consider something else, right? Cephalosporin, as I heard over there, maybe a carbapenem, depending on their history. If they need the Vanco, try something else. Try that cephalosporin. You can add Flagyl if you need the anaerobic coverage. A lot of patients with penicillin allergies, they're not true, and we can still safely use cephalosporins. So we should be considering other options when feasible. And so my 3 pearls today are going to be to avoid that single IV antibiotic dose prior to discharge. Please, dear God, avoid fluoroquinolones when you can. And then lastly, that Pictazo and Vanco or that Zanco combination. Thank you.